Hello students, in today's video we are going to discuss pharmacology of biological DMARDs, where DMARD stands for disease modifying anti-rheumatic drugs. Now as we all know, rheumatoid arthritis is an autoimmune disease. Immune cells like macrophages, T cells, neutrophils protect our body from toxins, noxious substances, infections, etc. But in rheumatoid arthritis, these immune cells attack healthy tissues of the joints, produce pain and inflammation, and as the inflammation progresses, there is destruction of bone and cartilage. So in rheumatoid arthritis, autoimmunity stimulates activation of immune cells like macrophages, T cells, neutrophils, etc. Now these activated immune cells produce a number of chemicals called as inflammatory cytokines. So activated immune cells produce multiple inflammatory cytokines, and these cytokines produce inflammation and further destroy the joints. Now one of the inflammatory cytokine is tumor necrotic factor alpha. It is a key inflammatory cytokine that is produced by macrophages. Now, tumor necrotic factor alpha binds to its receptors, namely tumor necrotic factor receptor 1 and tumor necrotic factor receptor 2. After binding to its receptors, it gets activated and produce inflammation. Now, tumor necrotic factor that is released by the macrophages, it further activates T cells, and it also activates osteoclast, and that is a bone destroying cells, and this tumor necrotic factor also causes multiplication or proliferation of fibroblasts like synoviocytes responsible for thickening of synovial membrane and the formation of pannus. And pannus is the structure that destroys the cartilage and bone of a joint. Another important cytokine is the interleukin 1. Interleukin 1 is also produced by the macrophage. It is also an inflammatory cytokine. Now interleukin 1 binds to interleukin 1 receptor, gets activated, and then it produces inflammation. Now as we all know, DMARDs are of two types: non-biological or conventional DMARDs like methotrexate and leflunomide, then biological DMARDs. Now biological DMARDs are classified as tumor necrotic factor alpha inhibitors. Now this category of drugs include drugs like etanercept, infliximab, adalimumab, then interleukin 1 antagonist, that is the Anakinra, and newer biological DMARDs like abatacept and rituximab. Now DMARDs produce potential adverse effects. Now adverse effects of biological DMARDs are more serious compared to non-biological conventional DMARDs. So first, non-biological DMARDs are used in the treatment of rheumatoid arthritis, and if these non-biological DMARDs do not produce good response, then biological DMARDs are used. So biological DMARDs produce prominent adverse effects, are expensive, and are used as reserve drug for severe refractory rheumatoid arthritis not responding to conventional DMARDs. Now before discussing pharmacology of biological DMARDs in detail, let's quickly go through the pathogenesis of rheumatoid arthritis and try to understand the exact mechanism by which bio-DMARDs reduce or prevent the progression of rheumatoid arthritis and save the cartilage and bone from the destruction. Now as we all know, in rheumatoid arthritis, immune cells of the body attack healthy cells and tissues of the joint. Now this is a figure that shows a healthy synovial joint. This is the healthy synovial joint in the pink color. Now this is the thickened, inflamed synovial membrane in a joint that is affected by rheumatoid arthritis. Now in rheumatoid arthritis, immune cells like macrophages, T cells, plasma cells infiltrate into the synovial membrane. They reach the synovial membrane, while neutrophils, they are seen in the synovial fluid. Now, activated T cells when activated produce cytokines like interferon gamma and interleukin 17. Now, these cytokines activate macrophages. Macrophages further produce cytokines like tumor necrotic factor alpha, interleukin 1, interleukin 6. Now, all these cytokines, they produce inflammation in the joints. Now, these cytokines also proliferate fibroblasts. Fibroblasts are the cells that are seen in the synovial membrane. So, these cytokines cause proliferation and multiplication of fibroblasts like synoviocytes, and this proliferation is responsible for the thickening of synovial membrane. So, the synovial membrane becomes thick and it gets inflamed, and this results in the formation of a structure that is called as a pannus. Now, pannus further destroys the articular cartilage and the bone. Now, these fibroblasts which were activated by the cytokines, they produce enzymes like proteases and matrix metalloproteinases. Now, these proteins, they further cause destruction of the cartilage and bone. Now, these cytokines, they also activate osteoclasts, that is the bone breaking cells that destroy the brain. Now, these T cells, these cytokines released by the T cells, they also activate the B cells, and B cells further produce plasma cells, and the plasma cells produce antibodies like rheumatoid factor, an antibody that is called as anti-citrullinated protein antibodies. Now, these antibodies also attack and destroy the joint. Now, biological DMARDs like tumor necrotic factor alpha inhibitors, for example, etanercept, it binds to tumor necrotic factor alpha, neutralize it, inactivate it. So, tumor necrotic factor alpha is unable to carry on the functions of inflammation and destruction of cartilage and bone. Similarly, interleukin 1 antagonist Anakinra, it binds to interleukin and it prevents it binds to interleukin 1 receptor, and it prevents the binding of interleukin to its receptor, and therefore interleukin 1 is unable to produce inflammation or cause progression of rheumatoid arthritis. Then newer biological DMARDs like abatacept prevent the stimulation of T cells. Then another biological DMARD, rituximab, destroys the B cells. So these biological DMARDs, they by inactivating these tumor necrotic factor alpha, by inactivating interleukin 1, they stop the process, they try to stop the process of inflammation, and if they are given in the initial stages of rheumatoid arthritis, then they prevent the destruction of bone and cartilage, and these drugs therefore they induce the remission. So, one of the most important property of DMARDs is this, that they produce remission, they retard or they prevent the progression of disease, they reduce or completely suppress inflammation, and therefore prevent the destruction of bone and cartilage. However, these DMARDs, they show potential serious side effects, so they should always be used in consultation with the physician. Now, let's first discuss tumor necrotic factor alpha inhibitors. The first drug is etanercept. Now, look at this figure. It shows a structure of human immunoglobulin or IgG, that is a structure of antibody. Now, this structure of antibody has two heavy chains. There are two heavy chains and there are two light chains. Now, apart from this, this region in the blue is the constant region, that is termed as FC, constant region, and this region in the green is the variable region. Now, look at this structure of etanercept. It is a fusion recombinant protein. Now, this structure in the red color is the tumor necrotic factor receptor, and this region in the blue color is the constant fraction of human IgG. So, etanercept is a recombinant fusion protein of two substances. One is the tumor necrotic factor receptor and other is the FC, constant portion of human IgG. Now etanercept bind to tumor necrotic factor alpha and neutralize it. So it binds to tumor necrotic factor alpha and inactivates it. Now this etanercept shows anti-inflammatory and immunosuppressant effect. Now it is the most commonly used biological DMARDs, and its efficacy is similar to that of methotrexate, and it is administered by subcutaneous injection 25 to 50 milligram once or twice weekly. So this is about etanercept. Now next tumor necrotic factor alpha inhibitor is adalimumab. Now MAB refers to monoclonal antibodies. So adalimumab is a monoclonal antibody. Now it's an anti-tumor necrotic factor antibody because it is an antibody that binds to tumor necrotic factor and inactivates it. So adalimumab is anti-tumor necrotic factor antibody. Now look at the structure of adalimumab. Now the structure of adalimumab is similar to that of the human IgG. This is the variable region in the green, and this is the constant region in blue. So adalimumab is a 100% human recombinant monoclonal anti-tumor necrotic factor antibody. So this is a tumor necrotic factor alpha. Adalimumab binds to tumor necrotic factor alpha and inactivates it. Now it is the most commonly used DMARD, and its efficacy is similar to that of the methotrexate, and it is administered by subcutaneous injection 40 milligram every 2 weeks. So this is about adalimumab. Now the next drug is the infliximab. Now infliximab, infliximab is also a monoclonal antibody, but it is a chimeral monoclonal anti-tumor necrotic factor antibody. Now it is termed as chimeral because it contains 25% mouse part. So it consists of 25% mouse and 75% part of the human IgG. So it is termed as chimeric as it is composed of this 25% part that is derived from the mouse. Now look at the structure of infliximab. Now this variable region, 25% variable region shown here in the yellow color, is derived from the mouse, and the constant 75 region is from the human IgG. Now infliximab is the first tumor necrotic factor alpha inhibitor that became available, and this infliximab, it binds to tumor necrotic factor alpha and inactivates it. Now infliximab, when given as a monotherapy, patient can develop tolerance due to the development of anti-chimeric antibodies. Now since infliximab is a chimeral monoclonal antibody derived from the mouse, use of infliximab can cause development of anti-chimeric antibodies, and these anti-chimeric antibodies can cause inactivation of infliximab that reduces the efficacy of infliximab and can cause tolerance to the drug. And thus infliximab is not used as a monotherapy. It is used in combination with the non-biological DMARDs. Now 3 to 5 milligram per kilogram of infliximab is infused IV every 4 to 8 weeks. Now again, since it is a chimeric antibody, now infusion of infliximab can cause an acute reaction comprising of fever, chills, urticaria, bronchospasm, and it can rarely cause anaphylaxis also. So this is about the infliximab. Now let's talk about the side effects of tumor necrotic factor alpha inhibitors. In fact, these are the general side effects of biological DMARDs. Now biological DMARDs produce prominent side effects, and these are more serious compared to synthetic or conventional non-biological DMARD. And thus first non-biological DMARDs are used for the treatment. If the required response is not obtained from non-biological DMARDs, then the biological DMARDs are prescribed, and thus biological DMARDs are used as reserve drugs for refractory rheumatoid arthritis not responding to non-biological DMARDs. Now, the adverse effects of these biological DMARDs, there is increased risk of serious or fatal infections like bacterial, fungal and viral infections, because biological DMARDs, they produce immunosuppressions, so the chances of infections are very high. Biological DMARDs can also cause a reactivation of latent tuberculosis. The development of malignancies like lymphoma, melanoma and skin cancers have also been reported. However, the actual connection between the biological DMARDs and these malignancies is not clearly understood. Then rare adverse effects like neutropenia, pancytopenia, thrombocytopenia, congestive heart failure, hepatitis, hypersensitivity, etc. have also been reported. So, these are the general side effects of biological DMARDs. Now, the next drug is the Anakinra. It is interleukin-1 antagonist. Now, interleukin-1, as we have already discussed, is a inflammatory cytokine which is produced by the activated macrophages. Now, look at this figure. Now, Anakinra is this is Anakinra shown here in the yellow color. Anakinra is a recombinant human interleukin-1 receptor antagonist. So, Anakinra binds to interleukin-1 receptor and it prevents the binding of inflammatory interleukin-1 to interleukin-1 receptor. So, it blocks the inflammatory action of interleukin-1. Since interleukin-1 is unable to bind to its receptor in the presence of Anakinra. Now, Anakinra is clinically less effective than tumor necrotic factor alpha inhibitors, and it is also used for refractory rheumatoid arthritis not responding to other DMARDs, and the dose is 100 mg subcutaneously daily. Local reactions and chest infections are the main adverse effects of Anakinra. Now, another biological DMARD is the abatacept. It is a co-stimulation blocker. Now, look at this figure. This is a T cell and this is an antigen presenting cell. Now, T cell is activated by two signals. One is the initial primary signal, other is the co-stimulation. Now, one of the signals is the combining of, when the major histocompatibility complex combines with the antigen, it causes stimulation of T cell. So, this is the first signal. Now, besides this, co-stimulation of T cells is mediated by the interaction of CD8T on the antigen presenting cell with CD28 on the T cells. Now, this is abatacept shown here in the yellow color. Now, abatacept binds to CD8T on the antigen presenting cell. So, abatacept blocks the interaction of CD8T with CD28 on the T cells. So, abatacept stops or blocks the co-stimulation of T cells, and in the absence of co-stimulation, T cell cannot be activated. So, abatacept causes inactivation of the T cells or blocks the activation of T cells, and if the T cells are not activated, then the process of inflammation in the joints is blocked or it stops. Another biological DMARD is the rituximab. Now, rituximab causes destruction of B cells. Now, destruction of B cell produces B cell depletion. Now, look at this figure. In the center is the B cell, that is the B lymphocyte in the pink color. Now, on the surface of the B cell are present CD20. Now, these CD20 are the differentiation markers. Now, rituximab shown here in the yellow color, rituximab binds to CD20 on the surface of B cell. Now, this binding between the rituximab and CD20 is responsible for the destruction of B cells by a number of processes. Now, one of the process is the induction of apoptosis. So, rituximab combines to CD20 and produces apoptosis or programmed cell death of B cell. Another method is by the activation of macrophages. So, rituximab combines with CD20 and activate the macrophages which destroy B cells by the process of phagocytosis. Another method is by the activation of natural killer cells. So, rituximab combines with CD20 and activates the natural killer cells. Natural killer cells produce cytokines that destroy the B cells. So, in summary, this rituximab, it causes destruction of B cells, and when the B cells are destroyed, their number reduces. So, this causes depletion of the B cells, and as this drug reduces the number of B cells, there is reduced generation of antibodies like the rheumatoid factor, and therefore there is a reduced destruction of the joints. So, this is how the biological DMARDs, they try to prevent or suppress the process of progression of rheumatoid arthritis, and this is how they produce the remission. So, this is in brief on the pharmacology of biological DMARDs. Please note that the information provided in this video is meant exclusively for the students. For the treatment of rheumatoid arthritis, consult your physician. If you find the video useful, kindly like, subscribe and share this video. Thanks for watching this video.